Hey everyone, I hope today is finding you well. My name is Zach Courier, and I have the pleasure of being joined by Ben Spielberg. How you doing today, Ben?
I'm doing pretty well. How about you?
I'm doing great. It's a pleasure to have you. You are the founder and CEO of TMS and Brain Health out in Los Angeles and Santa Monica.
hmm
Super excited about what I've seen. I've seen some of your interviews, pretty high profile stuff that you're doing out there, and so super excited to have you today and be able to speak to our community. Why don't you tell us from the beginning of where you kind of got into mental health and these types of modalities that you're offering and
hmm
where you are now.
Yeah, definitely. So before I start, I want to say hi to everyone. I'm waving. And also, apologies for the beard, which is kind of mid lockdown right now here in California. So, I've been in the field of mental health for over 10 years now. And at first, I started working in substance abuse treatment centers, doing different modalities, but mostly neurofeedback, which I don't know how familiar you are with neurofeedback, but it's essentially a way to monitor someone's brain waves and then sort of teach them how to change their brain waves, which correspond with clinical symptoms. So they'll
Also
have some,
referred to as brain mapping, right?
yeah, so the brain map, usually we do that initially. So you kind of get the baseline levels for how the brain is working compared to sort of a normal population, if you will, or a neurotypical population, I guess. And after that, you kind of set the computer to provide some sort of feedback based on where you're doing the training. So, for instance, if you have someone get the brain map and we see sort of abnormally slow brain activity in the frontal cortex, then we would tell the computer to sort of play a sound when someone is exhibiting faster activity in the frontal cortex. And so sort of you do this for 20 to 40 sessions, and you get a lot of relief, kind of depending on what the symptom is, but really effective for addiction, for pain, anxiety, PTSD, and things like that. So anyway, I did that actually while I was in undergrad, and I kind of realized that I wanted more of the hard science, so to speak. So I then went to Columbia and I studied neuroscience. I got my master's there. And when I was in grad school, I really became focused on this sort of overarching field of neuromodulation, which you could also call interventional psychiatry. So basically, there's so many different modalities that are available that a lot of people don't know about that don't just include medication management and therapy, which is mostly what psychiatrists do in this country. So basically, I researched a lot more about neurofeedback. I learned about transcranial magnetic stimulation, and I actually started working at a TMS clinic in New York in grad school. And I would even do brain mapping to sort of see if we can predict any off-label placements for TMS or off-label protocols. And my master's thesis ended up being on ketamine as well, and sort of the electrical physiological underpinnings of what happens during ketamine administration. So we would actually hook up people to an EEG machine so they would get their brain mapped, and then we would give them ketamine and we would watch in real time how their brain changes, which was pretty interesting. Um, so I kind of did all this. I got my master's, and then I realized that a few things happened. So one is that I saw that the FDA sort of cleared this shorter TMS protocol. So TMS used to be 40 minutes, and then the FDA cleared a 20-minute protocol, basically decreasing the space between the pulses. And then the FDA cleared this shorter 3-minute protocol. So I thought that was pretty interesting. So we started doing it a little bit more at the clinic I was at. And then I started to develop this real personalized approach with TMS. So basically, we have all of these parameters, right? We have frequency, we have placement on the head, we have duration of stimulation, we have number of sessions. So all of these things can really be modulated if you know how to do it to highly increase the effectiveness of the treatment. And so I sort of came up with all these different protocols, and that was kind of the impetus for starting my own clinic here in Santa Monica and now downtown Los Angeles as well.
That is amazing. That is so cool that, the vast experience that you got to have and how you sort of supplemented, your work experience with, the science behind it, and being able to, like you said, if you know how to do it, right, the theta burst side of things, going from 40-minute procedures, right, to 3-minute kind of theta burst, which is, it's just
right.
wild. Yeah, for sure. I feel like there's so many questions I could ask you, you know what I mean? But
Yeah.
first of all, I mean, you talk about interventional psychiatry. Why did we need to intervene? What was wrong with psychiatry? What was limited about psychiatry before sort of TMS came about, or ketamine started being used?
Right. Good question. So, psychiatry is right now, it's mostly medication management and it's psychotherapy, and both really have their place, right? Especially psychotherapy. I think the question is sort of what happens when those modalities don't work, because unfortunately they don't work for everyone. And so therapy, after a few months, if you're not going anywhere, usually someone will start to try medication. But unfortunately, the research shows that basically every trial of medication that doesn't work decreases the chance that the next subsequent trial will work by about 50%. So that by the time someone has tried 2 medications for depression, the likelihood that a third medication is going to work is going to be like less than 10%, which is low, right? And so the modalities like TMS, the research shows effectiveness of like 66%, right? Either response or remission, sort of depending on how you want to calculate that. Our personal data, because of this sort of personalized approach that we have, we see success in the 90%, low 90% range. And research with ketamine, which is another modality that we do, is it hovers between like 75 to 85%, and it works very fast as well. So I think that, interventional psychiatry really provides a need, sort of a almost procedure-based need, when the other modalities don't work. Because at the end of the day, depression is something that is in the brain. And so if you're not really modulating it with talk therapy, then what are you really doing, right? Are you really targeting what the actual cause is? So I think that's kind of the question, and that's the reasoning behind why we do what we do.
100%. And, it's interesting that you bring that up, because I've interviewed and talked with so many psychiatrists or people who run TMS machines, right? And everyone's numbers seem to be a little bit different. Everyone's way of going about it seems to be a little bit different. Some people say one issue that we have is sometimes people fall asleep in the chair. And it's like, well, that's not good. If the brain's not running, then that's not going to be effective. Some people are set it and forget it, and they watch Netflix for a while,
right,
in their treatment. Other people use that time to do the talk therapy. It sounds like more of what you're doing. So why don't you speak to a little bit of how your background, how your knowledge has kind of given you at least, a leg up or allowed you to be as successful as you have. Whereas sometimes, other places, again, may say, hey, this will help 6 out of 10, where you're saying, really, we believe 9 out of 10 are going to see significant improvement, based on your scales, right? Your PHQ-9 and things like that.
Right.
I guess I just want you to brag for a little bit, if you can.
I think the key with what we do is really the personalized approach. So first of all, we have different modalities. And I mentioned that ketamine works really fast. And so sometimes what we'll do is someone will do like 1 or 2 ketamine infusions while they're starting TMS, just to kind of get their brain to remember what it's like to not be so depressed. And then you kind of provide the TMS on top of it, so that they don't need the ketamine anymore. And it kind of works out time-wise really well. But, just for the people who do TMS alone, if they don't want to do ketamine, if they're looking for a non-medication approach or insurance or whatever the reason may be, it's really about knowing how to adjust all of the parameters. So we tend to start with one specific protocol, but after a few days is when we really start to personalize things. So if someone has irritability, we kind of know how to adjust things. We may adjust the duration, we may adjust the power level, we may adjust the placement. If someone has insomnia, we've developed a really amazing protocol for insomnia. It doesn't work for everyone, but I would say it works for about 50% of people within like 5 sessions or so.
Wow.
And so part of what we do when we target sleep is, we kind of know that the brain uses sleep to help reset, to help kind of store memories and grow in general. It's just sort of a healthy resilience mechanism for the brain. And so, we'll target mood, we'll target sleep, energy level, motivation, things like that. So during the session, we're always checking in with people, asking what their symptoms are, what's going on in their life. And then we're using that information to change the treatment parameters.
Amazing. Yeah, this has sort of been the year of the insomniac, right?
Yeah,
With school being
definitely.
messed up, with work being shifted.
Right.
We've seen sleep go out the window for a lot of people. More drinking, more
Hmm.
staying up late and binging on Netflix, more video games, this and that. So I think it's so important to address that and why it's important, and then how you guys have been able to help people who have really struggled with it chronically, right? I think
Yeah.
super
Yeah.
super important. We addressed TMS quite a bit. Why don't you tell us a little bit more about ketamine? I mean, some people realize ketamine as, okay, is that special K? Isn't that the street drug?
Yeah.
What's a
Hmm.
little bit of the history of ketamine? How is it advanced, even to FDA approval, right, through the Spravato S-ketamine,
Right.
right?
Right.
Why don't you tell us a
Hmm.
little bit of kind of the journey there and how you guys use it and what that entails if someone does receive ketamine treatments there?
Yeah, definitely. So it's pretty interesting. So, obviously it's been used as an anesthetic and as a pediatric anesthetic for, I don't know, it was FDA approved in 1970, I believe. So it's been used for 50 years in the United States. In the 90s, it became really popular as sort of a club drug like ecstasy and MDMA, and people kind of abuse them at raves and things like that. But what we found is that the dosage of ketamine really affects how people feel. And so
Mm.
if we use a sub anesthetic dose, so less than 10% of what people are using in anesthesia, it can actually provide really rapid antidepressant effects, which is fascinating because every other antidepressant basically takes like 4 to 8 weeks to really start working.
Mm.
And ketamine, because it has sort of a different mechanism of action in the brain, it's only, some people notice relief after just one session, which is really, really amazing to see when people walk into the office and they have, you can kind of see depression on someone's face, especially being in an environment like this. If someone's been suffering for a long time, you can tell. But then, sometimes they'll walk out of their very first infusion and they're smiling and they just they remember what it's like to feel happy again, which is really amazing to see. So yeah, it's really effective for mainly depression, PTSD. We found it to be really effective for. We do a few different versions of ketamine treatment. So mainly we have kind of created like a mindfulness protocol that we do before, after, and sometimes even during
Wow.
the ketamine administration. So like visualization exercises, breathing exercises, because what I realize is that there's basically this abundance of neuroplasticity that happens within 24 hours of the ketamine administration. And so if you can kind of capitalize on that, so to speak, and give the brain something to learn, it's really going to soak it up. And so if you learn a way to self-regulate yourself, then our theory is that it becomes a more effective intervention than it would be otherwise.
Wow.
Yeah.
You have intravenous and intranasal, or do you have to
We
be,
do.
how long does this process take? I believe, right, you have to be monitored for some time.
Yeah. So we have ketamine infusion sort of a la carte. So there's the general treatment course of that is 6 infusions over 2 to 3 weeks. There's kind of one specific dosage that we tend to start at, but just like with TMS, we try to personalize things as well based on their initial response. So we tend to go all over the place with dosage. There's also timing of the infusion in your bloodstream, and we modulate that as well, because that also has a big difference on sort of how long your receptors are saturated for.
Sure.
So those are the infusions. We also have, this is one of our newer programs. We're not even advertising it yet, but it's basically a comprehensive treatment program that combines ketamine nasal spray, TMS, neurofeedback, as well as group therapy and individual therapy in one package, which is very, very powerful, as you can imagine.
Yeah, speaking of powerful, we're talking about some heavy duty stuff, right? Ketamine treatments,
Yeah.
TMS treatments. It seems like you've kind of gone out of your way to make this accessible to people who are concerned about their healthy, keeping a healthy mental state and their mindset and things like that. So are you for everyone? Are you only for severely depressed, severely anxious people experiencing suicidality? Or where do people meet you and TMS and brain health?
Yeah, it really depends on what the person's goal is. So obviously we see a lot of people with treatment-resistant depression, treatment-resistant PTSD and anxiety, but we also have people who come in and maybe they haven't tried any medications and they don't want to be on medications, and that's fine. And actually that's the way it is in Japan. I don't know if you know that, but in Japan,
Train stops, right?
what?
They're on train stops, right? There are train
Train.
stops where you can get your TMS treatment. I thought I had just heard that recently.
I didn't know that. That's
I
crazy.
thought that's where you were going with that. Yeah, it's very accessible to the masses, what I've heard. But go ahead, say what you're going to say.
Right. Yeah, I didn't know they were on trains. So that's awesome. That's good to know.
I'll have to fact check that. We'll see in the edit there. Yeah.
Yeah. I can't wait. Yeah.
Yeah.
So in Japan, TMS is a first line approach, right? And I think that makes more sense because, medication is like a chronic treatment. So why would you do a chronic treatment when there is an acute treatment that you only have to do for 4 to 6 weeks to get relief that lasts, sometimes permanently? So I think they kind of have the right idea. So sometimes we will see people who just don't want to be on medication, which is fine. Obviously everything is on a case-by-case basis, but I wouldn't say it's just for severe depression. I would say like moderate depression as well. If it's something that, I think if someone's never been in therapy, maybe that would be a better, that would be something that's good to try first,
Sure.
at least for a few months, just because it's less of an overall burden to their life and their time. Obviously with TMS, you have to come in 5 days a week, or at least as close to that as possible.
Yeah, right. Yeah. Whereas you said, ketamine could be 6 treatments, but there may be a
Mhm.
little bit, it's a longer stay and this and that. So it's kind of
Right.
based on people's lifestyles. And what better year to look into it than this, perhaps, right? With everything.
Exactly. Exactly.
Uh,
Yeah, we have a lot of people who have kind of used this time as a way to give themselves treatment that they were avoiding for a long time. So,
it's a silver
you
lining,
know,
right? Yeah.
yeah, exactly.
Well, I won't let us get too into the weeds here, but I love to geek out with people like yourself as far as where you see the future of this going. We've talked in the past about things like psilocybin and MDMA, treating like ketamine is, right? Okay, we're seeing this kind of psychedelic drug now have these
Right.
unbelievable effects, for depression and for suicidality. And then, it seems like we're just scratching the surface of what could come. So without getting into it too much, what are you excited to see on the horizon for whether it be TMS or other modalities? What do you
Mhm.
see kind of the future of this becoming?
Yeah, so I think the biggest thing for TMS, I think we're going to see a lot of new indications within the next 5 to 10 years. So right now, obviously, it's only FDA approved for depression, but I think we're pretty close to PTSD, to chronic pain, to anxiety, traumatic brain injury. It looks very promising as well. So I think that's pretty exciting on the neuromodulation front. Um, Ketamine, obviously, a form of it was FDA approved for depression and suicidal ideation as of last week, I believe. But the ketamine compound itself is still not FDA approved for anything. So I think we'll see that pretty soon. On the I'm not that excited about psilocybin. I know a lot of people are, but
Mhm.
I need to see a little more data on that. But I am very, very excited about MDMA assisted psychotherapy for PTSD. The research that I've seen on it looks very, very promising.
Excellent, excellent. And then
Mhm.
maybe a little less fun subject. Do people have the opportunity to be reimbursed through their medical insurance with this? Is this all out of pocket, all out of network? How do you usually meet clients in that regard?
Yeah, so for TMS, we are in network with all of the major insurances, except Medicaid. But all the major PPOs were in network. We also take insurance for the comprehensive program as well, which combines all of those modalities that I spoke about.
Amazing. Well, Ben
Mhm.
Spielberg, this was an absolute pleasure. I appreciate you letting me pick your brain and geek out a little bit and being able to share this with the community. Again, just that piece of not enough people knowing about
Mhm.
what modalities are out there, right?
Right.
What is beyond talk therapy? What's beyond counseling, group therapy, med management, right? These are things
Mhm.
that are have actually been around for a while, even though they kind of feel like a well-kept secret. So I appreciate
Right.
diving in and educating us with that. I wanted to give you just any final thoughts that you have that you'd want to leave us with today. Floor is yours.
Final thought. I don't have any. I
You
think
don't have any. We've covered
yeah.
it. Yeah.
I think we've gone through it all.
Yeah, for sure. I think, one of the cool things that you mentioned being this year, people have sort of reprioritized things, right? And
Right.
put prioritize their mental health. So you maybe seen an uptick, and being able to treat more patients this year, which I think is amazing. And we wish you all the best. Keep up the good work, and yeah, go get them.
Thanks so much. Thanks for having me.
Take care, Ben.
All right. Bye.